Let's talk about AROM, or artificial rupture of membranes. The water bag is made up of two layers, the chorion and the amnion. Both layers need to rupture for the full process of AROM to be complete. There are two different ways in which a care provider will perform AROM, one of which is when they take a gloved hand and they place a little tool over a finger. It sort of slides on like a condom, and it has a little hook at the end. Then they perform a cervical exam. They reach up past the cervix and they gently snag the bag with that finger with the hook to break the amniotic sac. Another tool that is used is called an amni-hook. It's a long plastic rod with a little hook at the end. The care provider will insert their finger into the vagina and past the cervix, holding the hook in that finger. Usually the hook is facing towards their finger as to not snag any vaginal tissue on the way up. Then once they get past the cervix, they'll turn the hook around and they'll gently snag on the amniotic sac that surrounds the baby. Let's talk about the benefits. There is plenty of talk in the birth world of providers performing AROM to quicken the labor process. Speeding up labor has the potential of preventing someone from experiencing exhaustion. The research we have shows that AROM actually does not speed up the first phase of labor, known as active labor, but it does decrease the use of Pitocin in labor. Also, performing AROM in the second stage, known as the pushing phase, may support the baby in aligning in a better position if for some reason the person who is birthing has been pushing for a long time and the baby is not in an optimal position. The water bag may be really thick and may be holding the baby up. This is rare, but I have seen this benefit before. So AROM may resolve a prolonged pushing phase, and AROM may successfully induce labor. And for the case of someone who wants to avoid the use of medications to induce labor, AROM might be beneficial. Now let's talk about the risks. AROM may cause a temporary drop in fetal heart tones. This may be due to a vasovagal response from the baby as they drop further into the pelvis, or it could happen when the baby drops deeper into the pelvis without the amniotic sac in front of them and they compress against the cord, or they just move into a different position quickly without the water bag, which can cause them to compress the cord. This is often resolved by shifting the birthing person into a new position. I've seen hands and knees work wonders in these situations. This is why if someone is performing AROM, they usually have an assistant or an external fetal monitor monitoring the baby continuously as they perform the procedure. However, there is a risk of causing a drop in fetal heart tones that do not recover due to the baby compressing the cord or the baby coming down on the cord in front of the baby's head, known as a cord prolapse. This often means that the baby needs to be born by an emergency cesarean. Care providers should be trained to avoid a cord compression by feeling around the baby's head to ensure there is no cord in front of their head before they break the water bag. Performing AROM may be life-threatening in the case of a velamentous cord insertion. Normally, the cord inserts centrally to the placenta, which means it inserts in the middle. Sometimes the cord can be inserted on the side of the placenta, known as marginal insertion, and other times the cord actually inserts into the amniotic sac, with its vessels stretching across into the placenta. This means that if someone comes in and snags the amniotic sac over one of the vessels that is traveling across the sac, it can cause that vessel to rupture, which may warrant an emergency cesarean. Velamentous cord insertions are often identified during the anatomy ultrasound. So if the care provider is aware that you do have a velamentous cord insertion, they will not perform AROM. And the last risk is that the risk for infection becomes present. This is something you can learn more about on the AROM submodule.